And Israel, this case, if you showed me this picture, to me, I'm thinking to myself, very similar situation, very, very large defect. But man, look at that bone that you have on the buckle of number 26. How are we going to keep it?
Yeah, that's something that, you try to rotate that tooth as easily, as slowly as possible. And you go really, really slowly, try to keep that bridge, because you always want to keep that structural support like we're talking about. So for me, that structural support on 26 is key, and I'm doing everything I can to keep it.
I love how you degranulated almost first.
Yeah, and I look at this and I see all of the granulation tissue on the or the periosteum, little everything. I mean, this looks like a mess to me. I really hope I cleaned it up after the photo.
This it's a great photo for this point, because obviously in the last photo I just complimented the doctor on how well he elevated that clean full thickness flap. But look at that buccal almost exostosis you have, right? That ledge.
Yeah.
And that can get you caught up. So never be afraid to go back to the 15C and make sure that incision goes to bone, and you still may get caught with some of these tissue tags.
It's true. So that's that bridge of bone that I'm trying to keep on the facial of number 26. Well, Brandy just entered.
A lot of brandies.
A lot of brandies. Everyone's brandy tonight. So, as much as I try to keep that bridge of bone, sometimes you rotate that tooth and it's going to come out. It's a tiny little bridge. And no matter how delicate we try to be, sometimes it just doesn't stick. So, I have a little tiny half a bridge of bone there, and it was kind of cute, and I left it in place. Did it do much? No, probably not. But I like the looks of it.
So the biggest difference between this case and the previous case, obviously, is you have that lingual plate of bone.
Yes.
So now we're grafting within the housing. We're not trying to compare, apples to oranges. In this case, tenting screw not necessarily needed, because we have that lingual plate of bone. But you still need to
purely a horizontal deficiency with a thick ridge. So definitely no need for more structural support. Just needs to graft that defect. And put my membrane, do a rib roast, just like we talk about so much. This is sticky bone. You can see how it's in there and not really going anywhere. You can see in this case, I used a single vertical incision to just, we talk about this a lot. Like, you could always add a vertical incision later on. So obviously placed one distal the canines, the exact same spot as the last case we showed by the person who submitted the case. And I just kept one. The defect was more towards the patient's right side, and kept it only over there. Found I had good enough access, no need for a second vertical.
I think a good point here too is, if we're trying to get away without doing a second vertical, place your first periosteal bite furthest from the vertical. Yeah. So you still have access, for the periosteal biting later on. So that's a great point. But I love also this suture on the right side of your screen, almost on the mesial of tooth number 22. We don't really think of that, right? But we have to hold the membrane down, and you have that suture that's going interproximally, completely away from the defect, but it's doing something. It's holding that membrane down.
Yeah, and it's really because I decided to graft the facial of 23, 24 also.
Little PRF. You having any problems getting PRF tubes these days?
God, yes. They're like they're gold, and they're tough to get. Now and then we find a spot, we buy a whole bunch of them, but I'm always being told by my assistants that we're on our last batch, and then lo and behold, they find another spot. So we haven't really ran out yet, but it's always on the discussion points.
All right, so you did a beautiful periosteal release, I'm sure, and you probably had to release the lingual a bit.
Yeah, sure. Always have to bring it up, no question. And it's pretty easy to bring up the lingual tissue. The lingual tissue comes up really nicely. And one horizontal mattress suture, and some simple interrupteds on the vertical and on the crest, all glycolon, and wait a few months. This is probably 6 months of healing, and 6 months later, nice, good, solid bone. And remember that defect that we just saw right there in the bottom right corner. And now it's really good, solid bone. And unfortunately, the 23-24 were retreated endodontically, but still had residual increasingly in size lesions. And so we decided to extract those also. But look at the ridge on the CT scan. You can see that bone density, the amount of bone, really, really good quality. Be able to place my 2 implants in ideal prosthetic positions.
So the plan changed. Was the patient made aware from the beginning that the plan could change?
Well, yeah, because the patient had retreatment of there was discussion about removing all 4 incisors because there were lesions on all of them. Obviously, 25, 26 had a bigger lesion, and those are the ones that we had no question about taking out. But 23, 24, the endodontist said, you know what, give me one more shot at these. He didn't do the first endos, but he's like, central or central lateral incisor, give me another shot. Let me try to save them. And unfortunately, it was out of his control. So they didn't survive, but it's okay. Give it a shot.
And these are your customized healing abutments?
Yeah, I do a lot of those. Obviously, as you see, customized healing abutments are lab fabricated, but they are customized according to the prosthetic plan. So they basically marry the implant positions that are planned digitally with the prosthetic plan. And so all it is just, it's like you have an immediate provisional that's cut off at the gingiva. That's all it is. And they really help guide the tissue because you can see the lingual placement of the implants, and then the tissue would just be collapsed towards the lingual also if they were just round healing abutments. So this really pushes the tissue to the facial, and you end up with a nicer prosthetic result.
This is a series here. So the bottom is the final. You can see that nice tissue thickness without a tissue graft.
Yep. Without a tissue graft, good tissue thickness. You can see the good position of the implants. Have a screw retain little bridge. Good vertical height. Good horizontal thickness. And yeah, patient's really happy there.